I want to start with a medical mystery that, honestly, it felt like a riddle when I first read it. Imagine this. You go to the doctor, you have fluid leaking out of your ear. It's gross, it's annoying, your heaing's a bit muffled. Doctor does their job, cleans out all the gunk, makes the ear pristine, and suddenly, your hearing gets worse.
It sounds completely backwards, doesn't it? We're all programmed to think that, cleaning a blockage should restore function, not degrade it. But in the world of ear pathology, specifically chronic suppurative otitis media, or CSOM, logic has a funny way of flipping on its head.
Exactly. And that wasn't the only paradox in this stack of case files. I was looking at the file of a 64-year-old farmer who claimed she could hear better when people shouted at her. And then right next to it, a 20-year-old student who hears the shouting, he hears the volume just fine, but he can't understand a single word. Like everyone's speaking a foreign language.
And that distinction right there between hearing the shout and understanding the shout, that is the first major clue in what is, well, it's essentially a high-stakes detective story.
And that is our mission today. We are doing a deep dive into the world of the ENT specialist. We've got this stack of clinical presentations, ranging from that farmer to the student, and we're going to trace how a doctor looks at the history of a running ear, decodes the specific type of discharge, and yes, it gets pretty graphic.
Oh, it does.
And navigates anatomy that is terrifyingly close to the brain.
And I think it's important to frame this correctly. A running ear, or otorrhea, isn't just a hygiene issue. It's a sign of a breakdown in a very, very complex system.
So let's go back to those two patients, the farmer and the student. When I dug into the audiology notes, this seems to be the classic showdown between conductive hearing loss and sensorineural hearing loss.
Spot on. The 64-year-old farmer, she represents conductive hearing loss. Think of this as a mechanical failure. The sound waves are hitting a roadblock fluid, a hole in the eardrum, damage to the tiny bones, before they can even reach the inner ear.
So the nerve itself is just sitting there, waiting for a signal, perfectly healthy.
Precisely. The microphone is working, but the sound tube is blocked. And that's why shouting helps her. You're just pumping more energy into the system. Once that energy punches through the blockage, the nerve picks it up and processes it perfectly. She hears the volume and the clarity.
Which brings us to the student. He hears the noise, but no clarity.
That's sensorineural loss. The machinery getting the sound to the nerve is fine, but the nerve itself, or the cochlea, is damaged. It's like trying to listen to a radio station that's just slightly off frequency. You can turn the volume knob to maximum, and it will be loud, but it will just be loud static.
Right. Shouting just makes the confusion louder.
Exactly.
Okay, so that makes the farmer's diagnosis pretty clear. But this brings me back to that hook I started with. The patient whose hearing gets worse after cleaning. I ran into this term in the notes. The round window shielding effect. It sounds like something from Star Trek.
It's pure biomechanics. It's fascinating. To understand this, you have to visualize the inner ear. It's housed in bone, but it has two little windows connecting it to the middle ear. The oval window and the round window.
And for us to hear, sound has to vibrate those windows, right?
Yes, but, and this is the crucial part, it has to hit them at slightly different times. We call it a phase difference. The oval window gets pushed in, and the round window bulges out. They need to be out of sync for the fluid inside to move and stimulate the nerve.
Okay, I'm with you.
Yeah.
So what happens when you have a massive hole in your eardrum?
Well, sound just slams into both windows at the exact same time. The forces cancel each other out, the fluid inside doesn't move, no movement, no hearing.
But the patient with a dirty ear can hear.
Because that dirt, the pus, the mucus, the discharge is sitting right over the round window. It's physically plugging it. It acts as a shield, so sound hits the oval window, but it's blocked from hitting the round window.
No way. So the gunk is basically acting like a makeshift hearing aid.
In a way, yes. It artificially restores that phase difference. So the patient walks in saying, I have discharge, but my hearing is okay. The diligent doctor cleans it all out, removing that plug. And suddenly, sound hits both windows simultaneously again. The cancellation effect kicks in, and the hearing just drops.
Yeah, it is the ultimate paradox. You have to make them worse to eventually make them better. But obviously, you can't just leave a pile of infected sludge in someone's ear.
No, absolutely not. Because while that discharge might be helping their hearing temporarily, it's a sign of active disease that could kill them.
Let's talk about that killing them part, because usually we think of ear infections as painful. But in these chronic cases, the notes say that pain is actually rare.
That's a huge misconception. Chronic suppurative otitis media is typically painless. You just have the leaking ear and the hearing loss. So if a patient with a long history of a running ear suddenly says, Doc, it hurts, that is a massive red flag.
It means the infection has broken containment.
Exactly. It suggests the infection is eating into the mastoid bone behind the ear mastoiditis, or it's forming an abscess.
There were a few other red flags on the checklist.
Yeah.
Tinnitus and vertigo.
Tinnitus ringing in the ears, that can be a sign of some sensorineural irritation, but vertigo, that's a serious one for me. If a patient with a leaking ear starts getting dizzy, or the room is spinning, it means the infection is probably eroding into the labyrinth, the balance center of the inner ear.
And if it's in a labyrinth?
It's millimeters from the brain. You are knocking on the door of meningitis or a brain abscess. That's why we don't just leave the gunk in there.
Speaking of the gunk, or otorrhea, I made the mistake of reading this section while eating lunch. It turns out the discharge itself is basically a color-coded cheat sheet for the doctor.
It really is. You can often predict the exact bacteria just by looking at the color and consistency on the swab.
Okay, so I'm going to throw some colors from the case files at you. You tell me what's living in the ear. Let's start with yellow.
Yellow is your standard bacterial cocktail, usually Staphylococcus or Streptococcus.
Okay, what about green?
Green is almost always Pseudomonas. It has a very distinct pigment.
Brown.
Brown usually indicates a fungal infection, like Aspergillus.
And the one that sounded the most descriptive, curry white or creamy?
That's Candida, a yeast infection. It looks a bit like wet newspaper or, well, cream.
It's wild that you can narrow it down just by the palate, but there's another factor that seemed even more important than color, the smell. The notes say a foul-smelling discharge is a specific diagnostic sign.
Yes, and we aren't talking about just a bad smell. This is a very distinct rotting odor. It tells you two things. First, you likely have anaerobic bacteria bugs that thrive without oxygen. But second, and more alarmingly, it usually indicates osteitis.
Osteitis. Bone inflammation.
Bone erosion. The bone is literally rotting away. If you smell that foul odor, you almost immediately know you're dealing with an unsafe type of ear disease that is actively destroying the skull.
Bone rotting is a phrase that definitely wakes you up. Now, we've talked about the bugs, but looking at these patient profiles, it's not just bad luck. There are lifestyle factors that turn a manageable infection into a disaster. The case of the diabetic patient was terrifying.
Right, that's likely a case of malignant otitis externa. This is where diabetes turns a simple ear infection into a necrotizing, invasive pathology.
Malignant usually means cancer, right?
In this context, it doesn't mean cancer, but it behaves like one. It spreads relentlessly. In an uncontrolled diabetic, the immune system can't fight back, and the pH of the earwax changes. The bacteria, usually that green Pseudomonas we talked about, start devouring the soft tissue and the skull base.
And the protocol here isn't just give antibiotics.
No, The notes are clear. You cannot just operate your way out of this. You have to stabilize the diabetes first. If you don't control the blood sugar, the tissue will just keep dying.
There was another lifestyle factor that hit close to home for a lot of people. Smoking. I knew smoking was bad for your lungs, but I had no idea it had such a direct mechanical effect on the ear.
It's all about the mucociliary clearance system.
The conveyor belt.
Exactly. Imagine the lining of your middle ear and your eustachian tube is covered in microscopic hairs called cilia. They beat in a rhythm like a conveyor belt, sweeping mucus and debris out of the ear and down into the throat. It's the ear's self-cleaning oven.
And smoking shuts the power off.
One puff of smoke paralyzes those cilia for hours. Chronic smoking kills them. So the conveyor belt stops, the fluid stagnates, bacteria breed, and you get chronic infection.
Which explains why the surgeon in one case refused to operate until the patient had been smoke-free for 2 weeks.
Right, and it's not the doctor being mean. If you reconstruct an eardrum but the conveyor belt is broken, the graft won't heal. The ear will just fill up with fluid again and blow the new eardrum right off. You need those 2 weeks to let the cilia wake up and start working again.
Okay, let's move into the clinic. Patient is in the chair. I noticed a very specific rule in the exam section. Always examine the normal ear first.
The golden rule of otoscopy.
Is that just to put the patient at ease?
That's part of it, but it's mostly about calibration and contamination. First, ears are like fingerprints. You need to see what normal looks like for this patient before you look at the pathology. But more importantly, if you stick an instrument into a fungus-filled, pus-leaking ear,
And then stick it in the healthy ear.
you've just given the patient 2 infected ears. Cross-contamination is a rookie mistake.
After they look, they start poking. The tragal sign. This is pressing on that little flak of cartilage in front of the ear canal.
Right. It's a brilliant, quick way to sort the diagnosis. If I press your tragus and you jump through the ceiling in pain, it's likely not CSOM.
Really? I would have assumed pain means infection.
It does, but tragal tenderness usually points to an infection of the skin of the ear canal otitis externa, like a boil or swimmer's ear. The middle ear is deep inside. So if the tragus is painless, but the ear is leaking, you know the trouble is deeper, behind the drum.
It's a sorting hat for pain. I love that. Now, we have to talk about the part of the exam that I think confuses everyone. The tuning forks. Weber and Wren.
These are just classic physics tests.
Let's visualize the Weber test because the results seem backwards. The doctor puts a vibrating tuning fork right in the middle of your forehead.
Right.
And they ask, where do you hear the sound? Now, if I have a blocked right ear, say it's full of that CSOM gunk, I would assume I wouldn't hear it in that ear. But the notes say the sound lateralizes to the bad ear.
It does. It gets louder in the blocked ear. It's counterintuitive, but you can actually prove this to yourself right now. Listeners, try this. Hum a low note. You hear it in the room. Now take your finger and plug one ear tightly. Hum again.
Whoa. Okay, it's significantly louder in the ear I plugged. It's buzzing right inside my head.
That is the Weber test effect. By plugging your ear, you blocked out the ambient noise of the room. But the sound of your own voice, or the tuning fork, is traveling through your skull bones. Your bad ear is isolated from the competition of outside noise, so it captures that bone vibration much more intensely.
That's a fantastic way to explain it. The good ear is distracted by the world. The bad ear is focused on the vibration.
Exactly.
Now, there's a Rin test. This one compares bone conduction to air conduction.
In a healthy ear, air conduction is better. The ear is designed to catch sound from the air. So if I hold the fork next to your ear, it should be louder than if I press it against the bone behind your ear.
Positive Rin. Normal.
But in our CSOM patients, the farmer, for example, the air path is broken, the sound tube is blocked, so when you bypass the tube and press the fork directly against the bone, it's louder. Bone conduction is greater than air conduction.
And that confirms the conductive loss. Okay, so we've diagnosed the bugs, confirmed the hearing loss type. Now we're looking at the actual hole in the drum. I was surprised to see the sources classify these holes as safe and unsafe. It feels weird to call a hole in your head safe.
Safe is a very relative term here. A safe perforation is usually central right in the middle of the eardrum. It's called tubotympanic disease. It causes discharge, it causes hearing loss, but it rarely kills you.
Okay, so what makes a perforation unsafe?
Location, location, location. An unsafe perforation is usually in the attic, the very top part of the eardrum, or the margin, right at the edge. These are dangerous because they are associated with the villain of our story, cholesteatoma.
Cholesteatoma. It sounds like a tumor.
It's not a tumor, but it's just as destructive. Imagine the eardrum isn't just a flat sheet. If the pressure in the ear is messed up, part of the eardrum can get sucked inwards like a balloon being inhaled. This forms a little pocket.
Okay, so the skin of the eardrum is folded in on itself.
Right, and skin sheds. Usually dead skin just falls out of your ear. But inside this retraction pocket, the dead skin has nowhere to go. It gets trapped. It builds up layer by layer, forming a pearl or a cyst of trapped, rotting skin.
And this pearl is the cholesteatoma.
Yes, and as it grows, it releases enzymes that dissolve bone. It eats the hearing bones. It eats the bone covering the facial nerve, causing facial paralysis. It can eat into the brain case. That is why it's unsafe.
Yeah.
You cannot treat this with drops. You have to physically cut it out.
This leads us to the surgery section. The difference between patching a tire and rebuilding an engine.
Exactly. Ideally, if it's a safe central hole, you do a myringoplasty. You take a little piece of fascia from the muscle on the side of the head, and you graft it over the hole. It's a patch job.
But if you have that cholesteatoma, the bone-eating pearl,
Then the gloves come off. You need a mastodectomy. This is where the surgeon drills into the mastoid bone behind the ear to chase the disease. You have to drill out all those little air cells to find every microscopic bit of that skin cyst. If you leave one cell behind, it grows back.
it sounds incredibly invasive. You're drilling bone millimeters from the brain and the facial nerve.
It is high-stakes surgery, and the priority list, it changes. When you go in for a mastodectomy, the doctor tells the patient, my goal is not hearing, my goal is a dry, safe ear.
Hearing comes second.
Hearing is a luxury. Safety is a necessity. If we can reconstruct the hearing mechanism, do a tympanoplasty while we're there, great. But getting that time bomb out of the skull is the only thing that matters.
And once the surgery is done, there is one post-op rule that appeared in every single file.
No water.
None.
You have just built a delicate scaffolding inside the ear. If water gets in, it brings bacteria. The pressure changes can displace the graft, so no swimming, catch the shower water, and whatever you have to do. A wet ear is a failed ear.
It's a long road.
Yeah.
I read one case where a guy had been dealing with discharge for 15 years before he finally got the surgery. 15 years.
It's tragic, but it's common. People normalize the symptom. They think, oh, I just have a bad ear. They adapt. But as we've seen, that bad ear is a pathway for infection to travel straight to the center of your nervous system.
So as we wrap up this detective story,
Sure.
what's the big takeaway? We've gone from I can't hear to identifying green pseudomonas and drilling skulls.
I think the biggest insight is just appreciating the complexity behind a common complaint. We tend to dismiss ear infections as a childhood annoyance. But when you look at the mechanism, the conveyor belt of cilia, the pressure balance of the windows, the bone-eating cysts, you realize the ear is this incredibly delicate, high-performance machine. And when it breaks, fixing it requires a blend of physics, biology, and very, very steady hands.
And for me, I can't stop thinking about that round window shielding effect.
It's a paradox.
Yeah, the idea that the pathology, the goo, was actually holding the function together, it really challenges the way we think about healing. Sometimes, when you strip away the coping mechanism, things get worse before they get better. The dip in hearing after cleaning isn't a failure. It's a necessary step toward actual structural repair.
That's a beautiful way to put it. You have to clear the debris to rebuild the foundation, even if it feels like a loss in the moment.
A lesson for ENT, and maybe a lesson for life. Thank you so much for unpacking this with me.
My pleasure.
And thanks to everyone listening. Keep your ears dry, and we'll catch you in the next deep dive.